Dr. Robert Steiner, MD, is a pediatrician and clinical geneticist. He is clinical professor at University of Wisconsin School of Medicine and Public Health, where he sees individuals with SLOS. He's been caring for adults and children with SLOS and doing research in the field for more than 3 decades. Ladies and gentlemen, Dr. Robert Steiner.
Well, thank you very much, Andy, for that kind introduction, and thank you all for staying and not heading to lunch early. I do want to say a word about funding. That was a great question, a really important question. The government employees have to be a little bit careful about what they say related to governmental funding. I don't. What's happening in our country right now as far as funding for science, including biomedical research, is horrific. Funding has been cut dramatically, and the proposal for next year is also for dramatic, terrible cuts in funding. What you can do, obviously the foundation is very important, but they're never going to have the amount of funding necessary to carry the research forward. So contact your senators and your congressional representatives and ask them to restore biomedical research funding to where it was in the past. Thank you. Okay, so I have a number of disclosures relative to this talk. I think my serving as a consultant for Miram is the only perhaps relevant one. And I would say greetings from Marshfield, Wisconsin, where I live. But I would like to say my task today in terms of talking about the complications of SLOS has been made a lot easier by the previous talks. I won't have to go into so much detail. A lot of this will be repetitive, but hopefully by the end of the talk, you'll be very knowledgeable about the potential complications of the condition. I won't belabor the history of SLOS. You've heard that already, just to say that we're delighted that it was first described in Madison, where I work currently. So the clinical features, I'm not going to go over these in any detail, and we'll take these in individual order following this slide. Okay. Now, Denny already said this, but I think it's important to say again. The number of malformations or complications in an affected person with SLOS varies, with some having only 1 to 2 minor malformations, such as some webbing of the toes, maybe cleft soft palate, while others rarely have multiple or even nearly all key organs affected, and everything in between. So the specific clinical features of SLOS are outlined on this slide. I agree with Denny. I probably should have changed this slide. It's not failure to thrive, it's growth delay. Short stature, cleft palate you've heard about, broad nasal bridge with anteverted nares, bitemporal narrowing, so a narrowing of the head at the temple area, small head size, prominent forehead, small jaw with broad alveolar ridges. You've heard all this already. Webbing of the toes, especially between toes 2 and 3 in 85 to 95%. Proximally placed thumbs, extra digits, and genital anomalies, which range across the spectrum, anywhere from mild hypospadias to complete gender or sex reversal. And congenital heart defects, typically minor, but can be severe, even life-threatening. And then the gastrointestinal, neurodevelopmental, ophthalmologic, and other features. Again, you've heard most of these, and I'll go through these in more detail later. But just to mention them, pyloric stenosis, malrotation of the gut, reflux and constipation, Hirschsprung's disease, liver disease or cholestasis, brain malformations. So some babies are born with brain malformations, including sort of the classic one that's associated called holoprosencephaly. Intellectual disability is common but not universal. Autism spectrum disorders, very common. Feeding difficulties, challenging behaviors, ophthalmologic, cataracts, optic atrophy or hypoplasia, ptosis of the eyelids, and the skin photosensitivity, which Dr. Rizzo nicely outlined. Okay. Now again, this stresses what I told you in that earlier slide. The frequency of these complications can go from very rare or occasional to frequent to very frequent. Some clinical photographs. Some of your children may even be featured here. So what are the complications by system? I've gone through the slides pretty quickly, but now we'll slow down and go through these individually. So challenges with growth, feeding challenges, short stature or low height compared to average, typical. There are ear, nose, and throat complications, cleft palate, typically the soft or hard palate. That occurs in about 50% of cases in the literature and may adversely affect feeding, growth, and speech. Hearing impairment, hearing loss is quite common. Make sure all of your children have been evaluated, have had their hearing evaluated. Small jaw, which often is referred to, it can be a very recessed and small jaw. That is sometimes called Robin sequence or Robin syndrome or Pierre-Robin. All of those refer to a small chin or a small jaw or a recessed chin and jaw. There are orthopedic and musculoskeletal complications. We've talked about the proximally placed thumb. That's usually not a problem. It's just cosmetic. Low muscle tone, the webbing of the toes, polydactyly, and even ectrodactyly. Ectrodactyly is split hand, split foot syndrome. So missing digits in the middle and splayed fingers and hands, fingers and toes. Some clinical photographs of the polydactyly, the syndactyly. You've seen a lot of these already. The single palmar crease isn't too common, but in panel B you see a proximally placed thumb, and C as well. C has some self-mutilation scars from biting, and then several examples of the toe syndactyly or webbing, which can be quite obvious or even very hard to detect. And then genitourinary anomalies, undescended testicles, hypospadias. Dr. Porter defined that. It's when the opening of the penis isn't right on the tip. And in girls and women, hypoplastic labia majora and minora. Kidney malformations can occur, hypoplastic kidneys, aplastic kidneys, or cystic kidneys. Ambiguous genitalia. So we talked about the genital abnormalities a little bit earlier. And complete sex reversal can occur. So individuals who chromosomally are male with Smith-Lemli-Opitz can actually be phenotypically look female. And the congenital heart defects, a little alphabet soup here, PDAs, ASD, VSD, we won't go through all the details there, AV canal defect, but even things like hypoplastic left heart can occur in Smith-Lemli-Opitz syndrome and can be life-threatening or very difficult to treat. But again, thankfully, those severe heart defects are quite rare. There are lung anomalies that can be seen, abnormal lobation of the lungs, and hypoplastic lungs, lungs that are small and don't function as well as they should. So breathing becomes difficult. And then gastrointestinal anomalies, quite common. Gastrointestinal reflux, which some of your children suffer with, constipation, malrotation, where the intestines haven't rotated normally, and that can cause a number of problems with digestion, diarrhea, constipation, and even sometimes requires surgery. Hirschsprung's disease, which is, as Dr. Porter mentioned, an abnormality where the nerves that control intestinal behavior don't function properly, leading to typically to constipation and other gastrointestinal complications. We haven't talked a lot about liver disease and cholestasis. Cholestasis is where the liver doesn't function properly, so bile doesn't flow normally. Frank liver disease that's actually causing the kids to be sick or need some kind of therapy, again, thankfully is quite rare, but can occur. Cholestasis or liver disease would often be detected early on in infancy, but important to know that this can occur and to monitor liver function and liver enzymes periodically. Endocrine complications. Delayed puberty. I know some of you had some questions about pubertal development last night. Delayed puberty is quite common. In adolescent and adult females, menstrual function is often irregular following delayed puberty and delayed menarche. And then adrenal insufficiency has also been mentioned, where the body, because our Adrenal hormones are made from cholesterol. If cholesterol is deficient, we may not make the proper chemicals that are necessary for normal adrenal function, and steroids that are actually very important to protect us from stress. And then this one is a little bit long, apologies for that, but the brain is affected in a number of ways. Low muscle tone, learning disabilities, developmental delay, or intellectual disability, quite common but not universal. Sleep disturbances. I'm no expert in the sleep problems with SLOS other than I know they occur. We were studying them in our natural history protocol, and I don't have a good therapy for the sleep disturbances, but I know this will be discussed later, mostly tomorrow. Behavioral challenges, things like hyperactivity, self-injurious behavior, head banging, biting themselves, and temperament dysregulation are common. Autism spectrum disorder, Elaine Tierney in her group and Denny Porter in our group reported that autism spectrum disorder very common in Smith-Lemli-Opitz syndrome. Seizures can occur, although again, thankfully, those are rare, and microcephaly, brain malformations, and the classic brain malformation, which actually doesn't occur very common, holoprosencephaly, or abnormal development of the brain, so there's really only one lobe of the brain. Ophthalmologic complications are common. Ptosis, so the eyelids not opening all the way, very common. Often just a little bit of a cosmetic difference, but sometimes if the ptosis is severe enough, that can complicate vision, compromise vision, and so there is surgery that can be done for ptosis. Cataracts, which are typically cataracts at birth. Early onset cataracts that were not present at birth, not common in SLOS at all. And optic nerve hypoplasia, optic nerve atrophy, again, can occur much more common than in the general population, but still relatively uncommon. Dermatologic, we don't have to belabor this, it's the photosensitivity that Dr. Rizzo spoke about. All right, so maybe more important than just a nice catalog or a list of these things is what to do about them. How to optimize health given these potential complications. So there are some publications about anticipatory guidance. Margaret Novacek and Chris Wasif in their Gene Reviews article addressed this. Amy Kritzer and I in our recent review also reviewed this as well. So people asked about how often we should do the laboratory tests. It has been recommended every 3 to 4 months in the first few years and maybe once or twice yearly thereafter. But I will say my bias is really the same as Dr. Porter's. Don't pay too much attention to the numbers. It's more important how the kids are doing with their general health. The numbers will vary. Sometimes they'll vary for no apparent reason. And we don't have, unfortunately, specific therapies yet. Yes, we like to see the numbers periodically, but frankly, there's not a lot we do specifically to address those numbers other than recommend cholesterol supplementation, and you'll hear about Cholbam supplementation as a potential later on. And what we're typically measuring are cholesterol, 7-dehydrocholesterol, 8-dehydrocholesterol, and the serum transaminases are those indicators of liver function that I mentioned. Physical evaluation is probably the most important. So at every visit, we want to look at nutritional status, growth status, height, weight, and head circumference, development, and it's great if we're able to measure development objectively with measures like the Stanford-Binet or the Vineland. Behavior, look at anxiety, attention, aggression, and self-injury. Gastrointestinal, we physicians, we clinicians need to ask about the stooling pattern and whether there are any indications of liver disease or cholestasis. Neurological, we monitor for seizures, look for changes in tone and any movement disorders. Musculoskeletal, evaluate mobility. How are the children getting around? Are they able to walk unassisted or crawl? Vision problems, periodic vision screening is important. Probably yearly in childhood is recommended. And hearing screening similarly, at least yearly in childhood. You'll hear about some of the dental and craniofacial issues, so I won't belabor those. Endocrine we've talked about. Look for signs of puberty starting at age 10 and monitor for any delays, and consider referral to the endocrinologist to assist with pubertal monitoring and assistance. And then genitourinary. But more specifically, make sure your doctor is using the SLOS growth curves and not the standard growth curves to compare for height, weight, and head circumference. Feeding evaluations, very important. Speech-language pathologists, occupational therapists, sometimes swallowing studies are done, gastroenterologic consultation, and I think probably most of you have a dietitian as part of your team. I think that's very important. Don't overfeed your child to try to match typically developing children's growth curve. That'll just cause obesity. Ear, nose, and throat specialist evaluation can be very useful, along with the speech-language pathologist often. Hearing tests, audiology evaluation we talked about. And then when the jaw is small, typically nothing needs to be done, but sometimes that can actually contribute to the feeding difficulties, and even in early infants to airway problems breathing if the chin is so small. So referral to an ear, nose, and throat specialist, otorhinolaryngologist, if the children are symptomatic. And then to be reassured that the ENT problems are not contributing to the child's health issues. If weight gain and growth are normal, that's quite reassuring. Sometimes intervention is needed for the orthopedic or musculoskeletal problems. Proximally placed thumbs, again, typically no treatment is needed. Hypotonia, low muscle tone, that may improve with age. Physical therapy, occupational therapy are sometimes useful, and early intervention, birth to 3 programs, other early intervention and therapy services. The webbing of the toes, no treatment is needed. This is a normal variant, probably 1% to 2% of the population without SLOS has this. And then extra fingers and toes, or the lobster claw deformity, some surgery can be helpful to remove the extra digit or to repair the ectrodactyly to improve function and cosmetic appearance. Lots of different things can be done for the genitourinary anomalies. So for the undescended testicles, these often come down on their own, but occasionally may need minor surgery to bring them down. Hypospadias, if it's minor, doesn't need anything, just monitoring, but if it's severe, may benefit from surgery. Hypoplastic labia majora and minora, usually no treatment, no functional problems. Kidney malformations, which again are rare, but this needs monitoring if it is present, and surgery for malformations that can lead to urinary reflux or obstruction and frequent urinary tract infections. Ambiguous genitalia. So sometimes, especially the severely affected individuals with SLOS can have genitalia that aren't clearly male or female. They're sort of in between. It's important to assign the sex based on many factors, and sometimes surgery is useful. So the sex assignment is not based simply on genetics or chromosomal or the appearance. All of those things are taken into consideration, and you really need a specialist team to assist with sex assignment at birth when there's ambiguous genitalia. And for full sex reversal, monitoring the gonads, if they're testes or ovotestes, they can, if they're left in and they're not descended, can cause cancer later on. So sometimes those need to be surgically removed. Congenital heart defects, monitor if these are minor, but surgery if major. And for lethal heart defects, sadly, sometimes non-intervention may be offered. So palliative care, allowing nature to take its course. Again, tragic, but I think it's fair to say we don't want to take heroic measures for something where the end is really inevitable anyway. Pulmonary anomalies are rare, but for abnormal lung lobation or hypoplastic lungs, we need to support normal breathing as much as possible. Sometimes oxygen, overnight oxygen, or non-invasive ventilatory support are useful. Gastrointestinal anomalies. For reflux or constipation, dietary changes can be helpful, and sometimes medications can be very helpful. For true malrotation or Hirschsprungs, surgical repair is generally required. That's usually done in infancy if it's detected early, and these days very, very successful. For cholestasis or liver disease, close monitoring, dietary changes can be helpful, and medication can help as well. What about the endocrine complications? Well, in adolescent and adult females, menstrual function, as I mentioned, is often irregular. There can be delayed puberty. An endocrinologist should help with the monitoring, and hormonal therapy can be quite useful as indicated, sometimes to induce puberty or to maintain puberty. And then with adrenal insufficiency, as I think Dr. Elias mentioned, sometimes stress doses of steroids are needed. If children are not producing enough adrenal steroids that are important in protecting our health during stress, like infection or other illness, sometimes high-dose steroids are needed for short periods of time. The brain, we talked about OT-PT and early intervention for low muscle tone, special education for the learning challenges. Sleep disturbances, there are more and more sleep specialists that are knowledgeable about pediatric sleep disorders. Most of the large centers now, most large children's hospitals will have sleep disorder specialists. They can be incredibly helpful to your family in assisting with better sleep hygiene, allowing the kids to sleep better, and often medication can be used as well. For the behavioral challenges like hyperactivity, self-injurious behavior, or the temperament dysregulation, often it'll be helpful to see a specialist, in this case a psychologist and or developmental behavioral pediatrician. Again, medications, specific medications can be helpful. Autism spectrum disorder, you heard about the behavioral programs that can be really useful there. The same programs that are used in kids with autism who don't have SLOS. For seizures, a pediatric neurologist will often prescribe anticonvulsant medications. And for microcephaly, brain malformations, we need to support development to be as normal as possible with special education and early intervention. For the ophthalmologic anomalies and complications, ptosis, as I said, often needs no treatment, but surgery can be considered, especially if it affects vision or if it's cosmetically a serious issue. Cataracts are often removed surgically by the ophthalmologist, and optic nerve hypoplasia and atrophy are difficult to specifically correct, but the visual losses that are resulting can often be helped to some degree with corrective lenses or glasses. You heard about photosensitivity, what we can do there. Sunscreen, sunblock clothing, and avoiding direct sunlight are important. And dietary cholesterol supplementation has been shown to help with photosensitivity. SLOS and autism, we talked a lot about this already. At the time we published this, we thought this was one of the strongest links to autism of any condition. We still feel that way. Very important to look for an SLOS and to provide proper management. So I won't take the time to acknowledge everybody that's been involved. Funding was incredibly important to be able to do this work. And just real quickly, some of you remember Dr. William Connor, my mentor at OHSU, who passed away in 2009, just an amazing man. And Jerry Salin also passed away not too long ago. Really worked with Ellen and Mira in finding the cause of SLOS. And not many of you know Smitty, but he was an incredible supporter of our studies in SLOS and passed away a couple of years ago during the pandemic. So I will stop there, and if we have time for questions. This was my view from OHSU, and this is where I live now.
Thank you, Dr. Steiner. I'm curious to know what questions we have in the room. I see a hand up over here. Thank you.
Thank you. Mm-hmm. Thank you, Dr. Steiner. Very informative. I have a two-part question, if I may. We have two adult sons with Smith-Lemli-Opitz. Michael's 33 and Robbie's 29. I guess the first question is, what as children age, specific health conditions that they're not born with should we look at? And specifically, neurologically, do you see things developing later on in life? And I ask because our son Michael, all of a sudden, is having a hard time walking. We've gone to a podiatrist. There's no issues with his feet. We think it might be neuropathy. Going from walking very well to running to barely being able to walk around the deck or on an unsteady surface, completely unable to without support. And the second part of the question, I'd like to ask about stress dose steroids and some information we can give to clinicians about things that they might check that would warrant it versus not warrant it. Thank you.
Yeah, thank you. Those are great questions. I wish I had a better answer for the first question. The challenge is none of us have followed that many adults with SLOS. We just don't have a lot of information about the natural history of the condition in adults. I think we don't know of a lot of complications that occur later in adulthood other than what I presented here. If anyone has any additions, Ellen can speak after this. Or yeah, why don't we, Andy's got the mic now.
Thanks so much for that great talk, Bob. So in terms of the progressive problems with walking, I have worked with the neuromuscular team at my hospital and sometimes the physiatrist, and what we have noticed has been increasing tone in the lower extremities. That can be a neurologic phenomenon. Lots of your parts of your body don't work very well, but there can be a progressive neuropathy, it's called, in the lower extremities with increasing tone. And sometimes that's been managed by a rehab specialist or physiatrist. And there are other interventions for increased muscle tone with medications or interventions like Botox that have sometimes been needed to be used in some of my older patients. I think my oldest patient is 69. I have at least one in her 50s, several in their 40s and 30s, so I have seen that before. So that can be progressive over time. Another thing that can be progressive that wasn't on your list, Bob, is progressive retinal changes. So sometimes it's called a pigmentary retinopathy, where pigment gets deposited over time that can lead to some eye and vision issues. And one of the things I wanted to mention, I think it should be added to the ophthalmologic complications, because you can see it in childhood and gets worse as you get older. So to have your child to be evaluated by not just an optometrist who's assessing for glasses, but actually an ophthalmologist, who's the kind of eye specialist who's been to medical school and really knows a lot about vision, where they put eye drops in the eye and can dilate the pupil so they can get a really good look at the back of the eye and look for pigment changes. So it's really important in the older patients as well as the adults. And the last thing I was going to mention that I think should be added to the urologic list is hypertension. Hypertension is a pretty common problem in kids, and it's not just because you have a malformation of your kidneys, which is less common, but the membranes of kidney cells don't always function normally. And so many of my patients have developed hypertension as they have gotten older and into adulthood that requires treatment with medications for hypertension. These are the same medicines that anybody with hypertension might need to be put on. But it's important because hypertension can have lasting consequences and is a kind of a silent problem. There may be no symptoms at all from severe hypertension. It's something that pediatricians don't always measure when you go for a pediatric visit. But I always ask in my nurses and MAs to very carefully follow the blood pressure of children with SLO, just because hypertension is such a common problem, and it can progress and get worse as you go into adulthood.
We've seen hypertension as well. If we can keep the microphone at the front table for just a second, because you guys can help me with the adrenal steroids question. I don't routinely test my patients for adrenal function. I want to see if Dr. Elias or Dr. Porter do. I haven't had a lot of experience with adrenal insufficiency in my patients, but what I would say, and then I want to hear from them, is that if any of your children ever end up with at the hospital very sick, let's say with pneumonia, some other infection, and aren't getting better as fast as the doctors would suspect, I would have a low threshold for just treating with the stress steroids without even measuring anything. But let's see what the other doctors feel.
So I'll give this to you in 1 sec, Denny. So for kids with more severe disease, if the cholesterol is very low, then, and again, the level can drop with a severe illness and sepsis, or if your child is having a major surgical intervention, like a surgery for a heart defect or something like that. Then I almost routinely will work with the endocrinologist and consider measuring cortisol. Measuring cortisol is tricky because to really know, it's a special test that's done to measure adrenal insufficiency, and some of my kids have needed to have that. But I also, like Dr. Steiner, will consider empiric treatment with stress steroids, because there's really very little downside to doing that if your child is critically ill and just seems to not be getting better as you would expect.
Yeah, so when we started the natural history, we actually formally looked at that. Your everyday individual with SLOS is sufficient in terms of their adrenal function. There are cases in the literature of adrenal insufficiency. There tend to be in the more severe cases where you can actually show that, but I take the same tact. There's very little downside to stress steroids, so if a child has a major illness like hospitalization or a major surgery, what I suggest is that parents have the physicians contact us. Sometimes parents talking through to physicians, sometimes your point doesn't get across with a rare disease. I think it's easier for us to say, this is the data that's available, this is why we recommend it. So that's what I leave my patients with or parents with, is try to get your physicians to reach out and contact us, or vice versa. We can reach out and try to contact them.
That's really helpful. Thank you. Another question? There's one over here.
Any change in bone structure, particularly feet, hands, as children age?
We haven't seen that specifically in SLOS, and I wouldn't necessarily expect it. But if there is something occurring, how old, like in an adult?
Well, he's 16 now, but his
Yeah.
feet are just a lot. They're not pretty.
Yeah. I think the pediatric orthopedists are going to be the ones to help you the most, and if they can communicate with the geneticist and see if they can try to come up with an explanation, but I personally have not seen that.
I was just going to add, speaking of bones, that my daughter has osteoporosis,
Yeah.
and has for several years.
Yeah.
Why is that?
Yeah, I was happy to see that Dr. Porter's group is now doing bone density testing on the individuals. That's new. We did DEXA scans in some of the children, but we were mainly looking at body mass and not specifically at the bone. So this is data that's starting to come out. There are there's a risk for low bone mass or osteoporosis in people with SLOS related to their complicated feeding schedules. So we have to make sure there's sufficient calcium intake, vitamin D, and overall excellent nutritional status in general. So I think there is an increased risk for osteoporosis, but I don't think any of us have really published that yet.
Here's another question over here.
When we were at OHSU, you did do bone age scans, and both my boys had advanced bone age, and I don't know, but does that have any correlation, or will that be something, Dr. Porter, that I don't know enough about medicine to know if those are related at all, but I just know advanced bone age.
So bone age is measured looking at the wrist bones, and the wrist bones are sometimes abnormal in SLOS, which can make it complicated to determine accurate bone age. That's what we've seen. So it may not be so much advanced bone age, it may be irregularly shaped wrist bones in general. I don't think we've solved that issue yet. And bone density in children needs to be correlated with bone age. So it's a complex problem that I'm hoping Dr. Porter will solve.
We have one online comment. It's not a question, but Melissa said that FFP has been very beneficial when our son has been really sick. Last year, FFP was given for influenza and pneumonia. Saved him, I do believe.
Yeah, so FFP is fresh frozen plasma. That is a great source of cholesterol. There's a huge amount of cholesterol typically in FFP. This is a human blood product, so there are risks to using it. But it's something that can be considered just like stress dose steroids. If a child or an adult with SLOS is very sick, we don't know why. Sometimes FFP and or stress dose steroids can help.
Sure.
I've just got a question. You keep saying stress dose steroids. Is it different than regular steroids?
Really high dose that's only given for a very short time of several days, not weeks or months.
It's calculated, the dose that you need is calculated based on the patient's weight. And there is a very well-trained endocrinologist sitting in the back that maybe wants to give specifics, but a stress dose is not something you take every day. It's something you would take specifically with a severe illness. Yeah.
I have a quick question that I know the answer to, but others here might not. What if you have a child who is either non-compliant or non-verbal, and you want to find out more information, for instance, about their vision or their hearing or dental concerns? Could you say something about what steps you take?
Yeah, so pediatric ophthalmologists, pediatric ear, nose, and throat specialists, and pediatric audiologists are generally quite competent and familiar with how to evaluate hearing, vision. Pediatric dentists the same way with all of those things. But you'll want to make sure you're seeing a pediatric specialist specifically, and there are ways of evaluating vision and hearing that don't require compliance really at all. Now, sometimes with hearing, we have to sedate the children to do what's called an ABR test. And sometimes with pediatric dentists, we have to sedate the children. But there are ways of being able to do these evaluations.
And I'll just say, speaking for myself, when we were at the NIH and my son Juki had to be sedated for one procedure, that they were able to find out a great amount of other information about him while he was under, and we appreciated that.
Good, thank you. Thank you for the information on the stress dose steroids. If there was a suggestion box I could put this in, would be to maybe have a protocol available for providers to give to their providers in the absence of communication to the specialist.
That's a great idea. Thank you.
Thanks for that. Another question over here. Thank you.
Hi, I just have a quick question. Is gastroparesis the same thing as Hirschsprung's disease?
No, Hirschsprung's is a real anatomic problem that we can diagnose. Gastroparesis is difference in how quickly or slowly things go through the gastrointestinal tract. I haven't heard of that being a big problem in SLOS. It's something that can be temporary or permanent and can be helped sometimes with medications. There are specific medications for gastroparesis, but it is different from Hirschsprung's.
Thank you for that question. Any other questions? One over here, thank you.
Hey, Bob. Great talk.
Thanks,
So, really quickly, when you're looking at like SLS, historically it was diagnosed with basically the metabolites through mass spec, looking at cholesterol and the oxysterols. Now we have the ability to do genetic testing. So what, for the families here, what is your recommendation for getting diagnosed with SLOS? And is looking at the genotype, phenotype spectrum, and then also just trying to correlate those metabolites to a genotype. Thank you.
Yeah, thanks for the question, Jack. I recommend both biochemical and genetic testing in everybody with SLOS. There are some correlations, as you saw earlier, between cholesterol and 7 and 8 dehydrocholesterol levels and ratios, correlations between those and severity, and correlations between those and certain complications. And we do like to follow those levels and try to increase the cholesterol and decrease the dehydrocholesterol levels with interventions. So I think the biochemical assays, even if you weren't going to do that for diagnosis, we want those for monitoring anyway. So helpful for diagnosis and important for monitoring. I think the genetic confirmation is useful as well. There's a lot still to be learned about potential genotype-phenotype correlations, but I would say as of right now, there aren't a lot of genotype-phenotype correlations. In other words, we can't predict the severity or the complications of SLOS by the specific genetic variant that is present, with some exceptions. So for example, the severe common variant, if someone has 2 copies of that, they're generally going to be very severely affected. But other than those more general and few specific correlations, we haven't seen a lot of correlations. But the more information we have, the more data we have, the more children who have genetic testing, maybe those will emerge.
Thank you.
Thank you, Jack. Good question. Here's another question in the back of the room.
My son has, sorry, I get really nervous talking. So my son tends to develop fevers, especially like in the summertime when he's out in the sun. So I'm just curious, what are things that we could do because he's very active, he's very outdoorsy, and also does that go hand in hand with photosensitivity, or is that more just like body regulation?
Yeah, thanks for the question. I don't know that photosensitivity comes with increased temperature. I think typically it does not, so that would be unusual. I also haven't heard of a lot of temperature dysregulation or fevers in SLOS. I don't know if Denny or Ellen have seen that. It's not common.
Yeah. So kids used to get sick all the time and have fevers all the time. Oh, I'm sorry, thank you. And it wasn't so much related to being outside in hot weather, but just that were a lot of reasons for kids getting sick. If you're not well nourished, you're more vulnerable to getting sicker when you get some viral underlying infection. Kids with cleft palates tend to get lots of ear infections. Kids with urologic abnormalities can get urinary tract infections, which can just be subtle and present as a fever and you're not quite sure what's going on. So there were lots of reasons why kids got pretty sick and had recurrent fevers back in the early days. I think we're better at trying to figure out the underlying infectious causes that can go on, and also appreciate that kids were vulnerable to infectious disease because of their low cholesterol for many reasons. But I don't really think that the photosensitivity per se is associated, with increase in temperature.
I have a question actually for you. And does your son have problems sweating? No.
How high does the temperature get?
So he actually had, the highest fever he had from being outside was 103. Yeah.
What if you sweat, like you're not moving, you're not doing anything, but you're just constantly sweating? You just constantly sweat.
We've got a couple more data points in the room on this.
Mackenzie has the same problem. So we actually had it written into his IEP that he can't be in a room over 74.
Wow.
We did as well, and also they can't send him home when his temperature's over 100.
Correct, same. Yes.
That's really interesting. I don't think any of us have heard a lot about this before. So this is a new area of investigation.
That's fine. I've been reminded that people at home can't hear unless we're speaking into the mic.
I actually have more questions for you all. Sorry. So when you have this increase in temperature, any indication of infection, like infectious markers or anything like that? No? And then, so the one thing I could be thinking of is decreased thermal stability of the basically mutated protein with the increase in temperature.
So related to the other disorders in the same pathway. There are, Jack studies other disorders in the cholesterol synthetic pathway that have periodic fevers. And so there may be a link here, but it's not something we had noted before in SLOS.
Same thing with the other disorders. The temperature will affect the residual enzyme activity, and that will change the disease severity as well. So similar findings.
Since you all brought that up, we deal with excessive just sweating. He can just be sitting around in the house and he's just drenched. And I mean, he didn't have to be doing anything active or anything, and he's just pouring sweat. Would that be in correlation to what they're going through?
So I don't know. These are areas where we don't know and are interesting. You know, we mentioned about hypertension before. I think there is a component of what we call autonomic dysregulation in some of the kids. You know, blue hands, fingers that are not apparent necessary to cold. The hypertension may be related there. But I think it underscores getting information like that from parents gives us clues to try to look further to try to understand, because each child is different. Each child has lots of other genes, about 20,000 other genes. A lot of them interact with cholesterol synthesis, and so trying to put those stories together, it's only when we hear from parents time after time that this is an issue that you don't necessarily bring up when you're talking to your doctor. It gives us thoughts of where to go with investigations.
Speaking for myself, I'll just say that what Dr. Porter described is a good reason why we should participate in studies, that the results may help our children and other people's children as well.
A lot of psychiatric medications will increase sweating and also decrease the ability to respond to heat. Children we overheat and decrease sweating.
Thank you, Dr. Tierney. I think we're just about out of time, so this is a good time to thank Dr. Steiner for that excellent presentation.